One question that always comes up is, what is this concept of weights and plates? And how was that incorporated into the PRIMA trial? I think that it's important to understand that obviously there are a number of data sets that have shown fairly high rates of grade 3 and higher thrombocytopenia associated with niraparib. In an effort to decrease that particular toxicity, the investigators from earlier trials were able to see some cut points in terms of the patient's weight. And what they were able to do was identify a group that if they weighed less than 77 kilograms or had a baseline platelet count of 150,000 or less, they were more likely to have grade 3 thrombocytopenia. The other important part of this is they went back and looked at decreasing that dose and its effect on efficacy. So when you drop from the standard starting dose of 300 milligrams to 200 milligrams, based on the weights or the plates being the parameters I just named, you do not appear to have a diminution in the efficacy of niraparib. So how does that fit into the PRIMA trial? What they did is they instituted what is called personalized dosing, the weights and plates criteria, about 2/3 through the trial. And actually it's embedded in the label of PRIMA. And so you can get that data to show approximately half is the decrease in the grade 3, grade 4 toxicity that's associated mostly in thrombocytopenia and anemia. So I think it's certainly an effective strategy, but clinicians need to be aware of it, and they need to be aware of what the criteria are, and also understand how you interpret the PRIMA toxicity data as a whole.